topic is about the introduction and timing of blood purification in critical care. And the agenda going to be, the learning objective going to be blood purification technologies, indication for blood purification, when to start renal replacement therapy, and the goal of CRRT. Okay, so why I'm talking to you this is the biggest challenge for hemoperfusion in many hospitals is people are satisfied with SLED and CRRT, even though the survival of the patient is not that good. Many hospitals, they do CRRT for many patients. Some of them are not even recovered. So we need to open the eyes why these patients are not recovering after CRRT, what CRRT is lacking, and how hemoperfusion can support it there. Now, when we talk about today's blood purification technology needs, we know we have dialysis in chronic care, where we do the hemodialysis for the patient in chronic care. We have critical care treatment where then we have liver failure, the liver dialysis requirement, also poisoning. And we know Jeffron have a product in these 4 categories: in critical care, liver dialysis, poisoning, and chronic kidney disease. Now, if you look into this critical care, today's our topic, or these modules, our topic going to be critical care, how hemoperfusion is useful. Now, if you look into the history of hemoperfusion or the hemoperfusions, blood purification and the blood purifications, other kind of methods are, we can see that we have dialysis, we do have peritoneal dialysis, we have hemoperfusion, and we have CRRT, which is evolved from CABH, CVBH, then to the liver dialysis today. Okay, and today we're going to address what is the next in CRRT. Now, when we look into that, a little history is always good to know. 1977, that's the year, the beginning of this renal replacement therapy, other than dialysis, was planned. This is by Peter Carmore. He performed a CAVH therapy. And CAVH therapy is a very simple circuit. There was no machine used. They connected patient artery to the small hemofilter. It's a femoral artery mostly, with a single lumen catheter. Then with the blood pressure, the filtration is happened here. Then the return blood go to the venous or femoral vein. That was modified in 1983 by using a controlled machines like a syringe pump system, which can really control the fluid and ultrafiltration. That is in 1986. Come with more detail, like why don't we do with the veno-venous, means why you want to puncture the artery, because artery puncturing is very dangerous, very difficult to stop the bleeding. It also affects the patient blood pressure. So that's why in 1986, we come with the first generation of the CRRT machine, where they start CABH, CVBH, and CVBHD like therapy. You can see in 1990, this picture, the blue color picture, is the fully loaded 4-pump machine. 1995, when the Gambro, today the machine is taken over by Baxter, they came up with this machine called Prisma. Baxter is come with Prisma first, Gambro hard machine. Okay, and this was CVBH, CVBH, CVBHD flag therapy was done. And 2000, there was a guideline already in the plan, like a DOKI guideline, where they say 35 ml per kg can be a CRRT dose. Just like in last module, we discussed about the KT overview and our adequacy in dialysis. The same way in CRRT also, there was some adequacy was coming. Then if you see, there was a lot of improvement happened over the year. And 2002, they've come Prisma Flex, that was some of more advanced machine with more computerized technologies there. Then 2005, they come with the liver support machine, where the Mars was added. it is not that much popular because of its technicality and its cost of the treatment. I should mute it. Please mute your mics, all of you. Okay. In fact, there was a machine come from Fresenius called Prometheus for liver dialysis. Even that was discontinued. Then 2010, there is more blood purification requirement was come for lung support, citrate anticoagulation. And again, that's the time, 2010, hemoperfusion technology again awakened. It was sleeping for 20 years, 25 years. Only charcoal adsorption was quite famous there. That also very rarely used because of the side effect of charcoal adsorption. And then 2017, there are new generation CRRT machines come like multi-filtered Pro. In fact, there is nothing new in that, only touch screen and the costly bloodlines. But there is a company called Belco. They come up with 2017 come up with the 2 dialysis CRRT machine, one for pediatric and one for adult. In fact, they were also trying to incorporate adsorption technology with that. In 2018, 2019, we have the 4th generation CRRT machines, which is, as I said, which is come up with more modes, more than 10 modes on CRRT treatment. In fact, if you look into this, all this machine and this machine technology is involved. There was only involved the technology to make it user-friendly to the patient. But the basic principle of CRRT became same, just like the 1945's diffusion, osmosis, conversion. There's nothing much change. And that's why there's no much improvement in the patient's life also happened. Now, if you look into the goal of CRRT, continuous renal replacement therapy, it's an extracorporeal blood purification therapy intended to substitute for impaired renal function over the extended period of time and applied for aiming at beginning of 24 hours per day, which means in critical care, when the patient having a situation for blood requirement, the guideline always look into the kidney failure and treatment. It's quite interesting to know that CRRT, continuous renal replacement therapy, is intended for saving the acute kidney injury. And that's why if you look into the goal of the CRRT, there's no different than the goal of dialysis. The goal of dialysis and the goal of CRRT is almost same. Forget about this 4 paragraph I wrote here. Mainly provide renal replacement therapy to achieve the goal of electrolyte, acid-base balance, fluid balance, and remove the toxins. When it comes to the toxins, it was not much aware. Especially I have seen when the dialysis nurse or ICU CRRT treatment is done by a technician, they will always check the phosphorus, they always check the creatinine level, acid-base balance, electrolytes. That's it. And when they see that, okay, the creatinine is lower, they think they did successful CRRT. In fact, every time it's look like they will do the kidney very well, but the patient will not survive because this is the multi-organ failure patient. Patient have cytokines in the blood. Patient has so many other factors to remove. So it is our duty to educate the people the limitation of CRRT and the advantage of hemoperfusion with it. So that's what I really want to give a little idea, a little introduction about the blood purification technologies today in ICU. Today in ICU, most of our countries use hemodialysis or SLED for saving critical care patient. Some hospital, they go with CRRT in Asia. But I can show you some data. There's no evidence says that CRRT is better or hemodialysis is better. But there's evidence says that hemoperfusion is better if you start earlier, or hemoperfusion with CRRT or hemodialysis is better. So let's see now the indication for blood purification. Indication for blood purification, why I'm discussing with you is, then you can guide your nurses and doctors that when to use our product. When you look into the indications for blood purification, according to our catalog, it contains sepsis, septic shock, ARDS, MODs, COVID-19, severe pain, SAP, trauma, cardiac surgery. But for your information, it's more than that. It's more than that. The renal indications for blood purification ICUs are uremic symptoms like creatinine is high, patient getting breathing difficulty, overall fluid overload, electrolyte disbalance like potassium high, hyperkalemia, metabolic acidosis. But if you look into the non-renal indications, where we can talk about the severe sepsis, MOD, COVID-19, cardiopulmonary bypass, crash injury, leptospirosis, then see heart failure, acute pancreatitis, acute hepatic failure, intoxication, a lot. So these all the patients we really want to make sure that the doctors who are treating these kind of problems will be aware of hemoperfusions, and is important. You should plan some training program or CMA or some regular meeting to the doctors of all this category, not only nephrologist. But we know that traditionally, when it became blood purification, all the doctors are not taking risk. They will contact the nephrology. If it is cardiac ICU or if it's a surgical ICU, if there is a patient required a blood purification, other than ECMO and a heart-lung machine support, they will contact nephrology. That's why nephrologists are very important for us when it's come to acute kidney care or critical care dialysis. That is not only because, but there's a question, that's not something wrong, you know, it's not like people used to blame why nephrologist is involving there. Nephrologists are involving there because of the kidney is involved there. 35 to 65% of ICU admission is having acute kidney injury. 5 to 20% general hospital admission have acute kidney injury. The point is, all the acute kidney injury not required a CRRT or heme sled. Acute kidney injury also have stages, stage 1, stage 2, stage 3. Normally, there's stage 3, they think about doing a blood purification. The data shows that 1 in 5 adults having a risk of AKI in the hospital, and 1 in 3 children have a risk of having AKI in any ICU admission. So that's the reason your nephrologists are so much interested or involved or invited to treat this patient with the blood purification. So, but the thing is, the nephrologists always think about taking care of nephrons and the kidney. They should be knowing about the other doctor's requirement, the cardiologist, the pulmonologist. So there's a requirement of a teamwork in ICU to save the patient's life. But in fact, it's not happening. Even I was telling in yesterday on hospital training, and the nurses started laughing. It's truth. They agreed with me because the nephrologist come for the rounds, he saved the kidney. The cardiologist come for the rounds, he saved the heart. The pulmonologist come for the rounds, he saved the lungs. But who saved the patient? Nobody. So this is why the hemoperfusion and our Jeffron and you, all of you have something to do for this patient. Let's come back to the topic. When it's come to AKI, acute kidney injury, it's divided into 3: pre-renal, intrarenal, post-renal. Okay, and the pre-renal means the blood flow to the kidney is obstructed because of some problems. It can be severe dehydration, heart disease, blood clots, or even an accident. Imagine somebody had an accident and their blood flow is decreased and kidney is not getting sufficient blood. Kidney get failed temporarily, acute. Intrarenal is inside the kidney, there's some injury happening. Sepsis, glomerular nephritis, nephrotoxin drugs, which is used in life-saving in ICU. These are the things. Even crush syndrome, we talk about it. Myoglobin will go and block the nephrons. And postrenal is very rare. Postrenal normally because of the blockage of the urine path, maybe it can be urinary infection, which can be backflow to the kidney, whatever urine is coming, and kidney became injured. So this is what the pathophysiology of AKI. As we can see that, again, I explained to you that the perfusion is decreased because of heart failure. So you can get kidney disease every situation, kidney injury. That's what I am trying to say. Even the surgery can also lead to that. And this acute tubular nephrotoxicity, don't worry about this all terminology, but it is good that you're listening to me like that, because your doctors speak about all this kind of terminology. Okay, this is toxic agents like some of the drugs they use in ICUs are nephrotoxic. It will save the patient's life, but it will kill sometimes temporarily the kidney function. And all these antibiotics and chemotherapy, everything can be really a problem to do acute kidney injury. And this is one thing I want to tell you, the crush syndrome. What happened is when you get an injury of the bone get injured, and from the bone, this myoglobin will be released. And this myoglobin, when it's released to blood, it go to the kidney and it will block the nephrons and damage it. That's what crush syndrome is. In this presentation today, I will let you know all the indication for blood purification in ICU. So when the patient have a crush syndrome, they require a blood purification. There is a AKI. Now, COVID-19, there is data shows that it's also lead the patient to the acute kidney injury. Okay, so that's why COVID-19 also required a blood purification. Good. Now, cardiac shock in heart surgery, when the cardiac shock happen, heart failure happen, the patient can have a renal problem because the blood flow to the kidney is decreased. It can lead to massive fluid overload, and management will be normally renal replacement therapy in cardiac ICU. So these kind of situations, doctors really depend on the nephrology and nephrology nurse. So remember, nephrologists are important for our HA330 and HA380s promotion and usage. But the attention is moving away from there now in my presentation from nephrology, because we can see the most common case for AKI in ICUs are septicemia. And sepsis is a major reason for AKI, acute kidney injury, in most of the hospitals, number one. And number two is the major surgery and cardiac output, low, hypovolemia, and nephrotoxic drugs. So these are the major reasons for AKI in ICU, if you see commonly in global data, right? So that's why we should know the symptoms of AKI, which is fluid overload, electrolyte balance disturbance, the immune system get problem like cytokine releasing everything, and also it can lead to chronic kidney disease if you don't treat properly. Normally, just like your chronic kidney disease, 75% of function can be lost before it's noticeable in ICUs. And if you look into sepsis, the reasons for sepsis in the ICUs are actually the multi-organ failure syndrome, COVID-19, cardiac surgery, electrophoresis, AKI, acute. So this is really some of the indication of some of the reason for sepsis. That's a non-renal indication, which means the posting for the dialysis will be done by ICU doctors mostly. But unfortunately, the trend is like people don't do anything this time. People wait for the patient to get a kidney injury to start dialysis. And that's what I really want these 2 days to tell you, that is, we need to change their mind, because the sepsis is one of the potentially deadly medical conditions characterized by all body inflammation, which is called SIRS, severe infection. During the sepsis, large molecular-based substances like inflammatory markers, interleukin, and cytokines are commonly present in large quantity in sepsis patient blood. And this is a topic tomorrow. We will discuss detailedly about sepsis 3 and what is the treatment option and why we should do hemoperfusion earlier for that. Now, around 48.9 million cases per year, according to WHO, and 11 million deaths, 1 in every 5 deaths worldwide are associated with sepsis, especially in children. And it's very simple. I can have a small cut in my hand, wound here. If I don't properly take care of it, it can be a sepsis. Diabetic patients, if they have really some issues of, because they cannot sense it, because of diabetes, some legs, some bleeding or cut, it can lead to sepsis. It's easy to become anything tend to sepsis, blood infection, any bacteria attack. Today, let's have a look into sepsis, how it's happening. You know that the normal reaction of our body when there is a bacteria enter to our system, like I have a cut and some bacteria from my skin is gone there. We do have a system, our WBC system getting alerted. You can see that they will directly go there and they open up the blood vessels, epithelial cell. They will jump into the skin place. They will try to attack and eat up all these organisms. Okay, so this is really a body response. That's the way we are getting saved from any attack, any foreign pathogen is coming to our body. Whenever a foreign pathogen coming to our body, wherever it is, the WBC system, they do have different cells. I don't want to detail you that. They will go there. The good news is when these big cells, the macrophage, these cells when want to go there, the blood vessel will open up. They do have the key to open the wall of the blood vessel and go anywhere they want to go and kill this organism. After killing this organism, this cell himself will be suicide. Maybe I can say that, explore into small pieces. And that will be eaten by other cells in the blood. It's like a very good jungle story, you know, interesting story. But sometimes when it's become too much, it's going to be a problem. So now, if you see this video, you can see that it was like when there is a pathogen in the cell side and outside the vessels, the defense system will go outside and attack the organism and die themselves. But when they open up and go like this, the vessel wall get leaking. The vessel wall get leaking, which is going to make a blood pressure low, hypotension to the patient. All the organs will not get blood anymore. If it is massive. Sorry, why is coming again? Okay, so that is what the problem of this body's reaction to save our life became a problem or a killer to our life. Let me show you a small video to explain to you very easily that. Listen to that.
Triggered by a local infection, such as pneumonia in the lungs, an infected wound, or infection of the urinary tract. Should bacteria from the local infection spread or secrete toxic substances into the bloodstream, the immune system may sometimes go into overdrive, causing inflammation throughout the entire body. You get sepsis. This interferes with the blood flow, which leads to a drop in blood pressure, making it difficult for the blood to carry oxygen to the body's major organs. This can lead to failure of organs such as the lungs, the kidneys, or the heart. In the worst cases, the patient dies.
See, that's the problem.
Triggered by.
So in fact, what is exactly just now the video showed to us is when the patient has sepsis, our immune system try to defend it by breaking all the walls of the vessel when it's spread all over. Because of the immune system break the walls, we get leakiness in all of the blood vessels, which reduce the blood flow to the main organs. The first organ always to fail in sepsis is lungs. That's why the first treatment they're getting is ventilator. The patient who are in ICU first go to ventilator because the first organ is affected is lungs. Second is kidney. That's why they require renal replacement therapy. Then is go to the heart. If it is more organs fail, it's very difficult to save the patient's life. Tomorrow we will talk, when we talk about sepsis 3, about cytokine storm and what is cytokine, what is good cytokine, bad, what is ugly. We'll discuss it. But to make you all easy to understand, this statement from Sir William Osler in 1904 is quite relevant in our today's life in ICU. Prasdeep Shah, can you mute your mic? Thank you. Except on a few occasions, the patients appear to be die from the body's respond to infection rather than from it, which means even we do in our daily life this problem in our psychological life. Like we normally get trouble with our relationships just because of our overreaction than the situation there, which means sometimes our words, our overreaction, our action is spoil relationship. Sometimes it will be a family relationship. Sometimes it can be our colleagues in the job. The same way, when the body get an infection inside, let's say bacteria, most of the time patient die, not because of bacteria, because of the overreaction of the body, the overreaction of the immune system. So that's what sepsis actually mean to be. So when this body overreact, when we get so much cytokines in the blood, it really create MOD, multi-organ failure. It can be triggered by sepsis. It can be triggered by COVID, hypovolemic shock, and severe trauma. But anyway, all of them are connected together with sepsis. As I say, generally, the lungs are the first organ to injury. Then acute kidney failure will come. So you can see that once the sepsis is spread, once this patient is having less perfusion, the blood flow is decreased. One by one, all these organs failed. The whole body going to be in a collapse situation. And the patient's survival, mortality and severity is based on how many organs are failed. If kidney only failed, you can treat the dialysis or CRRT, save the kidney, patient will come back to you. It can be easy. If kidney plus heart is failed, it's going to be a little more difficult. If kidney plus another 2 more organs are failed or 3 more organs are failed, it's going to be very difficult to save the patient. So the best thing is today, the ICU doctors are thinking about prevent this multi-organ failure from 1, 2, 3, 4. And you don't believe there's a new focus is going. You can even prevent even the kidney failure by using hemoperfusion. We will talk it tomorrow. And that is what I really want all of you to help me to talk to your doctors and introduce them this idea. This is not about selling the products. It's about saving people's life and saving a lot of money. We will see it in coming days. Now, as you can understand, during the COVID infection, because of this COVID virus, aggressive inflammatory response of the body will happen. Pro-inflammatory cytokines, again, a lot will be available or will be released or formed in our blood, which create a cytokine storm. The cytokine storm, again, what happened? They will leak the blood vessels, will make MOD. So if any of you are believing that we use HA-330 to treat COVID patient and their lives saved because of HA-330, it's a wrong idea. We have nothing done. Our HA-330, nothing done to save the COVID patient by treating COVID. We never treat the COVID. HA-330 COVID, the cytokine storm. Because of HA-330 treated cytokine storm, the COVID patients survived. And cytokine storm is there in sepsis, severe burn, post-cardiac surgery, pancreas. There are a lot of situations is there in ICUs where cytokine storm is killing. And we need to educate our customer. You can use HA-330 for any kind of situation for cytokine storm. If sepsis-induced cytokine storm is there, you help to save the patient in sepsis. If it is acute pancreatitis or liver failure, you help to save the patient there. So not only COVID patient, please erase that thing from your brain and also from your customer. Hemoperfusion using HA-330 saved the patient COVID with removing the cytokines, not treating the COVID. Now, why I said that is, we have a very good reputation in the last 2 years in many countries that COVID patients survived because of hemoperfusion. Everyone knows it. And use that platform as a stepping stone for introducing this product to other places. So you can see that the pathological mechanism of sepsis in AKI, when the sepsis happened, the blood flow to the kidney will decrease. That way the kidney will get a problem. Plus the inflammatory markers will increase a lot of issues with the nephrons, glomerulus, and it's also make an internal kidney injury. So what you can see here is the sepsis and AKI is interconnected. 22 to 67% of chance of AKI is because of sepsis. 47.5% sepsis is caused AKI. So it's really connected together. If I can talk to you, when the sepsis is too much, the inflammation too much, it creates multiple organ injury. It makes the blood pressure low. It makes hemodynamic renal blood flow low, and it makes the microcirculation in the kidney low, and it makes AKI. And look into the AKI make uremic acidemia, fluid accumulation, and the catheter exposed to the extracorporeal circuit, which will make an immunoinfection and sepsis. So AKI patient can be sepsis, sepsis patient can be AKI. It's a very scary thing. I know it's totally different than what we spoke last modules. This is about ICU dialysis. Since it's quite a difficult one, let me just check that how much you're able to understand so far what I said. You can type in your chat box these answers, true or false. First question. Sepsis is the most common case for AKI in ICU. This statement, true or false? Type in your chat box. What do you feel? All of you, okay? All of you. Anyone can type in the chat box the answer. Yeah, I'm getting the answers. Shibu, thank you. Shibu says true. Okay, what about others? Yes. Kanagaraju, yes. Sudi, yes. True. Deepak, okay, very good. Very good. Vietnam also, Thailand also, very good. Very good. Allow that. So you are very well aware about that part which I discussed. I'm very happy. Second statement. CRRT is an extracorporeal blood purification therapy intended to substitute for the impaired renal function, which means, in simple language, CRRT is save kidneys function only, or CRRT is made for doing the function of kidney replacing by that therapy. So that's what. This statement is true or false. We do CRRT in AK to support kidney. That's it. Okay. True. Yes. Yes. So when you say true answer, you remember, just now I talk about this SEPSIS. There's nothing we do with SEPSIS and inflammatory markers. That's why in COVID also, we go for hemoperfusion, not for CRRT. Some hospitals go for CRRT, but the outcome is different. It's true, yeah, everyone, thank you so much. So you understand, doing CRRT for a sepsis patient, yeah, it will support the kidney function, but not going to do anything with sepsis. There are some new membranes some companies coming out with. We'll talk about it coming days. One more question. Large molecules such as inflammatory markers, interleukins, cytokines are commonly present in the blood of patients with sepsis. This statement is true or false. Large molecular substances such as inflammatory markers, interleukins, and cytokines are commonly found in patients with sepsis. All right? True. Very good. Love it. This shows that how much you are knowledgeable about this subject. So all of your answers are right. All the statement is true. So keeping that in mind, let us see the next part of our presentation, which is indication for blood purification. When I talk about indication for blood purification, as I said, this is one top priority research subject in ICUs. In fact, nobody knows when to start renal replacement therapy. Some doctors start early, some doctors start late, some doctors do SLED, some doctors do HD, some do CRRT, even CRRT, they have CVVH, CVVHD. It is very big costing now, tomorrow, or later. The optimum timing for starting dialysis in AK is not defined yet. You can look into any guideline, even DOCIC guideline. There's no RCTs so far saying that when to start treatment. And this can be a good advantage for us to promote hemoperfusion, because since there's no guideline, we can make some patient to convinced, sorry, some doctors to get convinced, start hemoperfusion before AKI. It is widely accepted that patients with severe hyperkalemia, severe acidosis, pulmonary edema, and uremic complications should be dialyzed emergently. That's what they do that. When the creatinine is high, they pause for dialysis. Okay. Now, if you talk about the timing of renal replacement therapy in AKI, the DOCIC guideline is say, the chapter 5.1, initiate RRT emergently when life-threatening changes in the fluid, electrolytes, acid-base balance exist. Still, they say not guaranteed. Outcome is not guaranteed. That's why I say there's no RCTs. Otherwise, they consider the border of the clinical contracts start the renal replacement therapy, which are severe hyperkalemia, severe acidosis, pulmonary edema, and uremic complications. Now, this is why it's a big challenge that whether to provide renal replacement therapy, when to start, are the two fundamental questions facing by nephrologists and ICU doctors in most cases of severe AKI. Let's watch this TikTok video together, and please do not share this with the nephrologist.
Wait a second. Why is this patient getting dialysis? Yesterday, she had 4 functional nephrons. Bill? I don't know, boss. Did something happen last night? Well, the nurse said she had a little bit of chest pain. What? Cardiology. Psst. Hey, what's going on? Nephrology and cardiology are arguing again. What about it? Oh, nephrology always thinks they can avoid dialysis even if the patient only has like 1% of a kidney left. Okay? And cardiology wants to treat the heart even if it means destroying every other organ in the process.
If you really talk to the nephrology nurses or the ICU nurses mainly, they will really laugh a lot with this. They will really agree, yes, it's right. What is the outcome or, take home message of the TikTok video is, the cardiologist found the fluid is accumulating in the heart and patient is getting a heart failure. And the cardiologist want to remove the fluid. So the cardiologist posted the patient for dialysis to remove the fluid, to save the heart. But on the nephrologist side, nephrologists know that AKI in the first stage or second stage, they can treat with the medications and some other kind of adjustment. So they also know that the dialysis have its own lot of side effect. CRRT have a lot of problems to the patient. It can give dialysis, also can drop the patient BP and make the situation best. So normally they try to delay the requirement of renal replacement therapy because of its complication. But some doctors in other departments, to save their organs, of course, in this TikTok video, it's heart cardiac surgery, he think about it. So there's a conflict. And some hospital, it's very strictly said, nobody going to touch the dialysis machine without the nephrologist permission. But somehow, anyway, the thing is, what is the point I want to tell you is, it's a big question.
Wait a second.
It's a big question when to start renal replacement therapy. Renal replacement therapy, it means it can be SLED, it can be PD, it can be HD, it can be CRRT. And in the high risk stage 1, nephrologist will not do any dialysis. Stage 1, okay, you can see the indication. Stage 2, where they need to check for the changes of drug dosing and considering about renal replacement therapy, solely considering, okay, and move the patient to the ICU. And when it becomes stage 3, they will try to avoid the catheter if it's possible, because it can make sepsis. So now this is it. You can see the arrow here. In stage 2, some doctors consider about starting a renal replacement therapy in ICU. And normally in stage 3, it will be too late, became MOD. Now, there are some study is showing that if you early start renal replacement therapy within 24 hours of reaching stage 3 of AKI, and if you start 24 hours later reaching AKI, the mortality is lower with early RRT. P-value is 0.01, 51.5 or 77.9% is the mortality. So you can see this graph. The patient who start early dialysis in ICU had more survival rate than late. This is again not much well known. So now there's a guideline definition. There are 2 guidelines mainly nephrologists are following: DOCIC guideline and refill. DOCIC guideline says that increase serum creatinine by 0.3 within 48 hours, you can consider it. Or increase serum creatinine up to 1.5 times baseline with the urine output decreased. Similar, you can see the risk, injury, failure, loss. See, I don't want to explain all of this to you, but if I'm doing a training to the nurses and hospital, I really explain this detail. I wanted to know that they follow these guidelines, and that's not enough. That's not enough to save this patient's life, because, sorry for my slide to move. As I said, this already we talked about it. They are really waiting for the patient to have a renal injury stage 3 to start patients in critical ill like dialysis therapy. This is another one of the study. Early initiation within 8 hours of diagnosis of pedophile stage 2 and delayed within 12 hours of stage 3. And you can see the outcome. So it's really a big topic there. It's a big research topic there, which is good for that. Early initiation can improve metabolic hemostasis, volume balance, body temperature. Therapy contributes to stabilize the circulation, improve the patient clinical outcome. That's what they say. But in contrast, early initiation may unnecessarily expose the patient to possible adverse effect associated with the treatment, which patient will not maybe, I mean, that's the point, the side effect of the blood purification. I mean, HD or SLED. But same time they say it's a confusing word. Late initiation can, let me remove this from here so again, may contribute to the worsening the patient condition as a result of metabolic disturbance, fluid accumulation, and circulation of uremic toxins. So this statement is really very funny, you know. It's a journey. It's one of the Netherlands journey of critical care. They say early initiation is good, but it can risk patient from the dialysis. But if you make it too late, it can risk the patient from the complications. So this is why I say one of the big problems. If they decide to start the therapy, what is their options? PD, some poor countries and children's, some poor patients, still they think about continuous cyclic PD. Yeah. Intermediate hemodialysis, IHD, 2 hours of dialysis they do per day. Then SLED, sustained low efficiency dialysis. That's nowadays a lot they're using. 6 hours with 100 to 150 pump speed, 300 ml per minute dialysis flow and concurrent flow. Then the next option we're having is continuous renal replacement therapy, CRRT, using the CRRT machines. These are the 4 options today traditionally following everywhere for treating the patient with acute kidney injury or ICU needs.